We're going to discuss the other aspects of the adrenal disorder, mineralocorticoid excess. We have seen glucocorticoid excess, glucocorticoid deficiency, we have seen. We are going to see the mineralocorticoid excess, otherwise called hyperaldosteronism. Okay. The first description of the patient with aldosterone producing adrenal adenoma is done by Dr. Kahn. That's why this is called Kahn's syndrome. So this is an adenoma he reported. Mineralocorticoid excess was thought to represent a very rare cause of hypertension in those days. Now we know from literature that around 5 to 10% of hypertension is mineralocorticoid, which is very high. If you see 100 hypertensives, 10 of them may be mineralocorticoid. That means what you have to do, you should look for it. And then it's a treatable hypertension. You don't have to treat him lifelong. To control the mineralocorticoid excess, the problem is done. Okay? So that is an important message. It is not rare, first importantly. The prevalence is higher when the patients are screened and selected correctly. What is the screening criterion I use? Hypertension, hypokalemia, young individual. Hypertension not responding to more than 3 drugs. Two drugs. These 4 issues are there. There is a fellow with hypertension. He is 30 years, young man or young woman. She has got hypertension. And then it is not responding to my conventional treatment. When I looked at the potassium is low. Mineralocorticoid. I have picked up n number of patients of mineralocorticoid using these 4 criteria. All hypertensions are not idiopathic primary hypertension. There is a part of secondary hypertension, which is a treatable, completely correct. The most common cause of mineralocorticoid excess is primary hyperaldosteronism. Means what? Primary is from the gland, not from elsewhere. It is not under the control of pituitary anyway. Mineralocorticoid is under the control of REA system, renin-angiotensin system. And it is not an excess of renin that is the cause. It is primarily from the adrenal gland itself, which is the zone which is manufacturing zona glomerulosa. Okay. Now, what are the causes of mineralocorticoid excess? Common causes of mineralocorticoid excess are adrenal adenoma. There is a small benign tumor in the adrenal gland in the zona glomerulosa that is producing more of mineralocorticoid. Second one, bilateral micronodular adrenal hyperplasia. Micronodular adrenal hyperplasia. That can also result in glucocorticoid excess. If the nodules happen to be in the zona glomerulosa, it will be mineralocorticoid excess. There is one important condition, a rare but very important condition called the glucocorticoid remediable hyperaldosteronism, GRH. This is a very good important short note. You will be asked what is glucocorticoid remediable hyperaldosteronism. I will tell you about that. What it is and how to treat that, I will tell. Primary hyperaldosteronism, adrenal adenoma Kahn syndrome is one common cause. Bilateral adrenal hyperplasia is the other important cause. And glucocorticoid remediable hyperaldosteronism is the other important cause. That doesn't mean the list is complete. So we need to see, this is from the Davidson textbook. So now, imagine there is excess of aldosterone in the body. What will happen to the feedback mechanism? Renin should be suppressed. It is not under the control of pituitary. So nothing to do with the ACTH or pituitary tube here. It is under the control of the, you also come here so that I don't have to shift my gaze this way and that way. Yeah, can say. So, whenever there is excess of aldosterone, primarily from the gland, what it will do is it will suppress the renin axis. So there will be low renin. That means renin values are low, angiotensin, aldosterone values are high. There is a ratio, ARR ratio, angiotensin renin ratio, angiotensin numerator, renin denominator. Angiotensin is high, renin is low, the ratio is very big. Isn't it? A by R. Angiotensin, aldosterone by renin. Aldosterone is the numerator, renin is the denominator. Aldosterone by renin is the ratio. So the ratio is very high. That means it is called low renin situation. Renin is low, aldosterone, hypertension. Sorry. The screening criteria for hypertension for aldosteronism is anybody who is young, anybody who has got hypertension, and who has got not responding to conventional treatment with 2 or 3 drugs. And the fellow has got hypokalemia. You can use this criteria and pick up 1 case of hyperaldosteronism per month. Start now. All hypertensives, whether a young fellow you see, look at the response, they are not responding well. Look at the potassium. Potassium is low, means you are in for diagnosis of hyperaldosteronism, which is a treatable condition. Unlike primary or idiopathic hypertension, which is a lifelong treatment. You reduce salt, you do this, you walking, you dance, you stand upside down, all those things you have to say, plus the drugs. Here the problem is simple. Remove the mineralocorticoid excess, the problem. Now, when I classify the etiology, I require to know there will be a high aldosterone, low renin group. The other is aldosterone, the renin axis itself is elevated due to some reason, and that is producing secondary aldosteronism. For example, heart failure. In heart failure, secondary hyperaldosteronism will be there, cirrhosis of liver, all fluid retaining conditions. Wherever there is sodium excess, the renin axis is activated and produces more of aldosterone. That is called high renin, high aldosterone. There is another group of conditions where the renin is more, nor the aldosterone is more, that the fellow is showing features of sodium retention, hypertension, and all that. That means somebody else is doing the mischief of mineralocorticoid. So non-mineralocorticoid thing is acting on the kidney to retain sodium and produce protein. You understand? So these are the 3, that's what Davidson is simply listing. High renin, high aldosterone, secondary hypertension. Low renin, high aldosterone, primary hyperaldosterone. Renin low, aldosterone also low, non-aldosterone dependent activation of the mineralocorticoid pathway, some miscreants other than the regular cell. Okay. Now, what are the conditions in the high renin, high aldosterone, which is secondary? We already know very well: heart failure, liver failure, nephrotic syndrome, renal artery stenosis, renin secreting renal tumor, very rare condition, and people who are put on diuretic therapy. Some of the diuretics, they have the tendency to retain sodium and excrete potassium. Okay, and some diuretic therapy, cardiac failure, liver failure, nephrotic syndrome, RAS, renal artery stenosis, are the causes of high renin, high aldosterone, secondary hyperaldosterone. You understand the mechanism? Now, the more common one is the primary one among the adrenal disorders. Secondary is, of course, very common. Among the primary ones, adrenal adenoma is the most common. That is the Conn syndrome, idiopathic bilateral adrenal hyperplasia, glucocorticoid dependent hyperaldosteronism, or glucocorticoid suppressible hyperaldosteronism. Though rare, it is a very important condition. I will show you what it is. In these patients, renin will be low, aldosterone will be high. The ratio will be very high. Whereas in the earlier case, the ratio will be low. Because renin itself is high, aldosterone is low, A by R, aldosterone by renin ratio is low. So always in evaluation, you must look at both renin and aldosterone to find out. Just as we have looked at cortisol and ACTH there, here we have to look at the renin as well. So the last category is low and in low aldosterone, non-aldosterone dependent activation, like ectopic ACTH syndrome, licorice misuse. This licorice inhibits the beta hydroxylase, and then the Liddle syndrome, 11-day cortisone secreting adrenal tumor, rare forms of congenital adrenal hyperplasia where 11B hydroxylase deficiency is there. Okay. Now, etiology is same, just now whatever we have said is the etiology. Bilateral micronodular adrenal hyperplasia is more common than the unilateral adenoma. Bilateral adrenal hyperplasia is usually micronodular but can also have macronodular, which could be mistaken for an adenoma. A rare instances, adrenal carcinoma. Coming to the adrenal disorders proper, adrenal adenoma is the most. Micronodular hyperplasia, bilateral is next common. Unilateral is less common, can be mistaken for a solitary adenoma, rarely adrenal cancer. So, still rarer causes may be there, like syndrome of apparent mineralocorticoid excess. There is no mineralocorticoid excess, but the situation, symptoms, presentation will be like an apparent mineralocorticoid. Cushing syndrome can present with, sometimes extremes of Cushing syndrome. You not only have cortisol excess, some of the cortisol gets converted into mineralocorticoid and gives glucocorticoid, resistance adrenal carcinoma, congenital adrenal hyperplasia, progesterone-induced hypertension. This is the most common in case of pregnancy, hypertension where the progesterone levels are very high. That is the reason people in pregnancy-induced hypertension, PIH is the cause. Okay, this is a table from the Harrison. Looks very complicated. Don't look at all that. Look at the left-hand side of that. The right-hand side is understand. What is that? First one is primary. Under the primary, adrenal adenoma, bilateral micronodular hyperplasia, glucocorticoid remediable hyperaldosteronism, also called GRH. What is that? I will tell. Okay. The treatment for that fellow is small dose of dexamethasone. That is why it is called glucocorticoid remediable. If a glucocorticoid, the whole problem is solved. Small dose, 0.25 milligrams of dexamethasone every day. You give the whole problem. Why it occurs? Other causes, the syndrome of mineralocorticoid excess, looking like, same, and then the Cushing syndrome, glucocorticoid resistance, adrenal causes by all. Now, how does it present? Okay. What we have already listed? Sodium excess will be there, potassium low will be there, symptoms of these two things will be there. Sodium excess causes edema, hypertension will be there, and then lack of potassium causes muscle weakness, muscle paralysis, particularly in Southeast Asian population. There will be polyuria because of excess sodium. There will be triggering of the secondary renal tubular damage, nephrogenic diabetes insipidus occurs. Occasionally, there will be hypocalcemia, alkalosis, alkalotic tetany. Patient may come with tetany because of hypocalcemia and metabolic alkalosis. And blood pressure is elevated, but there is no accelerated phase. That means you don't see the eye changes, retinopathy, and all that you don't. So that's not accelerated hypertension, elevation of blood pressure. General picture. Now coming to more specifically, the excess activation of mineralocorticoid receptor, MRA mineralocorticoid receptor, leads to potassium depletion, increase in sodium retention, later causing an expansion of the ECF and plasma. Increased ENAC activity, also the extracellular sodium activity, also results in hydrogen depletion that can cause metabolic alcoholism. Aldosterone has a direct effect on the vascular system. Aldosterone is a direct stimulator of the vascular system. Cardiac remodeling can occur. Diastolic function is decreased. Aldosterone excess can cause direct damage to the myocardium, to the glomeruli, and secondary damage due to the systemic hypertension. The hallmark of mineralocorticoid excess, okay, that is very important. So the hallmark of mineralocorticoid excess, as I have already told you in the beginning, hypokalemia, hypertension, serum sodium may be elevated, may be normal. Normal why? Because of the fluid retention, dilutional hypometry. Hypokalemia may be associated with muscle weakness, proximal myopathy, hypokalemic periodic paralysis. So we had a young fellow, around 20-year-old boy. He came with hypokalemic periodic paralysis. When we evaluated him, he turned out to be hypertension. And the hypertension is a mineralocorticoid. We treated him. So everything has settled very well. So this is how we have to think about whenever we have the hypertension in the young. Of note, patients with primary aldosteronism show increased rates of osteoporosis, type 2 diabetes, and cognitive dysfunction also. So osteoporosis is common just like glucocorticoid excess, mineralocorticoid excess also is osteoporotic. And type 2 diabetes, just like glucocorticoid excess, produces hyperglycemia. Mineralocorticoid excess also can produce type 2 diabetes. Significant proportion of the patients suffer from concurrent mild autonomous cortisol excess. Not only they have mineralocorticoid excess, they also have cortisol. Because the same micronodules are there in the fasciculata also, then they produce that also. That is called Cushing syndrome. Cushing plus Cons. It's called Cushing syndrome. Cons syndrome, Cushing syndrome, named it as MACE. That is concomitant excess of the mineralocorticoid also. And that is called the Cushing syndrome, a new terminology. Now, excess activation of the mineralocorticoid receptors leads to what? Potassium depletion. Mineralocorticoids, the MR receptors, their function is to retain sodium and excrete potassium. That retains sodium, excretes the potassium. Sodium retention, along with that, water also is retained. Extracellular fluid expansion and increased RNAC activity results in the hydrogen depletion, and that causes metabolic alkalosis. What is the concomitant metabolic abnormality? Metabolic alkalosis. That's why alkalotic tetany or tetany may be due to hypocalcemia also. Aldosterone has a direct effect on the vascular system, not only on the mineralocorticoid receptors, it acts on the blood vessels also and increases the cardiac remodeling and decreases the diastolic compliance, mainly direct damage to the myocardium and glomeruli can occur and secondary damage to the systemic hypertension. This diagram we have already seen earlier. The circulating blood volume influences the kidney perfusion and that stimulates the juxtaglomerular cells, releases the renin. Renin converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted by ACE enzyme to angiotensin 2. And angiotensin 2 is a potent stimulator of the AT1 receptor that produces aldosterone release through the glomerulosa, and that produces sodium retention, and that increases the circulating blood. So this is the cycle. Then this is about the mineralocorticoid hormone action at the receptor level. So that is the gate. ENAC is the gate at the distal tubule. An epithelial cell in the distal nephron or the distal colon also is depicted. Distal colon, we are interested more in the distal nephron. There that ENAC is the gate because of the mineralocorticoid receptor. This one, what happens is that gate is open. Once the gate is open, sodium will enter inside and that sodium is retained. And in exchange, potassium is thrown out. Okay. And you see the downward arrow, aldosterone acts on the MR receptors act on the structural proteins within the cell. And then the gate is open, the gate is prepared, and the gate is pushed onto the exteriorized onto the membrane for the sodium to come. Okay. Now, the clinical hallmark of mineralocorticoid, already I told you, hypokalemic hypertension, fluid retention, peripheral edema. Another important thing is, because thiazide diuretics are given for hypertension, if the fellow is hypertensive, you put him on a thiazide diuretic, the hypokalemia worsens. Thiazide diuretics by nature, we know that they are hypokalemic in nature. Already this fellow is hypokalemic, so the symptoms worsen. Now, what are the symptoms of hypokalemia? Muscle weakness, proximal myopathy, periodic paralysis. Severe alkalosis can contribute to muscle cramps and, of course, tetany. The tetany, the underlying mechanism is metabolic alkalosis, alkalotic tetany, or maybe due to hypocalcemia also. Should I screen everybody, whoever comes to the outpatient? Should I screen everyone? No, not like. What you have to do? Select them. Hypertension, which is drug resistant hypertension. You have given 2 or more drugs, patient not respond. Young fellow, hypokalemia, and incidental adrenal mass. On doing an ultrasound, they found an adrenal mass or hypertension below 40 years. Young individual, hypertension, adrenal mass, not responding, hypokalemia, or the basic screening level. Then you start evaluating the mineralocorticoid disease. So again, the same thing is listed here. Severe hypertension, 3 or more drugs are used. That's called drug-resistant hypertension. Hypokalemia, adrenal mass, another family issue. So because some of these are genetic syndromes, adrenal hyperplasia and all that. So if he says, my father was a hypertensive in a very young age, and I am also hypertensive at the age of 40, the chances of having a familial disease running is the cause. So young hypertensives always look for the family history also. No. This is the algorithm which we have to slowly work out. First, you see, algorithm for the management of patients with suspected mineralocorticoid excess. Suspected, who are the suspects? The first paragraph is that severe hypertension, more than 3 BP drugs not useful, hypokalemia, adrenal mass, family history, young. Okay, that is the first thing. And if the screening criteria are positive, then you go down to do further screening. Otherwise, if he is not young, if it is an elderly person, there is no adrenal mass and there is hypertension is responding to drugs, there is no hypokalemia, there is no reason to suspect. So you don't have to do this all the remaining tests. So what is the first test I do? The test is aldosterone renin ratio, ARR. Okay. There is a catch here. Renin is always dependent upon the antihypertensive drug. If the fellow is taking antihypertensive drug, the renin itself may be lower because the antihypertensive suppresses the renin. So you have to take the fellow off the drug and then test him. If I take the fellow off the drugs, already is not responding. If I remove the drugs, is hypertension. Then what do I do? So you have to slowly see that what you have to do is first correct the hypokalemia. What I do, I give sodium potassium chloride, KCl syrup or tablets of potassium and supplement him for a week or so. The potassium part first gets corrected. Then the renin automatically will try to adjust to the original level because potassium has returned to somewhat normal because of it. Then you can give alpha blocker, calcium channel blocker, you can give. These drugs do not interfere with the hypertension. Like calcium channel nifedipine, philodipine, nitrandipine, or your newer calcium channel blockers also, cilnidipine, or any one of those drugs you can give, along with alpha blocker, alprazosin, those group of drugs you can give. Diuretics, not those which are interfering, like thiazide diuretics or spironolactone. You can give other types of triamterene or some other drug. And first step is what I should do? Replenish the potassium. Withdraw the antihypertensive medication, particularly ACE inhibitors, CARs, because these are directly known to act through that mechanism. Maybe beta blockers also, but the newer generation beta blockers like carvedilol, bisoprolol, nebivolol, these are better when compared to propranolol, atenolol, and those. Okay. Then what do I measure? I measure ARR. ARR means angiotensin renin ratio. If the angiotensin is high and renin is lower, the ratio is going to be higher. That is the primary group. The other group is angiotensin is lower, renin is higher, the ratio is lower now because the denominator is high, renin. So that is a secondary group. Then look for secondary causes. What are the secondary causes? Heart failure, any fluid retaining condition, cirrhosis, and then renal related water retention, renal artery stenosis. Okay, so these are the conditions. Now, we did the measurement of aldosterone ratio. on concurrent blood pressure medication, stop spironolactone for 4 weeks. With hypokalemia corrected, ARR screen positive. When do you call it as positive? ARR is more than 750. That is, angiotensin is so high, renin is so low, the ratio is more than 750 picomoles per liter. Okay. Supposing and aldosterone itself is more than 450. Supposing that it's not to that level, then you can repeat it after the stopping the beta blockers also. And anyway, you would have stopped the angiotensin receptors and ARB80 blockers, and then again re-eval. The two situations can occur. It may be negative or it may be positive. Suppose it is positive, then the next step is confirmation. So first is clinical screening, then is biochemical screening, then confirmation. For biochemical screening, what I did the ARR ratio. It is not today your patient comes, tomorrow you cannot do. You have to withdraw the antihypertensive, right? Particularly AT1 receptors and ACE receptor blockers were avoided. Calcium channel blockers can be given. Alpha blockers can be given. If he is on beta blockers, better stop them also. Look at the ARR. If the ARR is more than 750 and if aldosterone value is more than 450, then he is probably a case of adrenal hypercortisolism. How do I confirm? Then there is what is called the saline infusion test. 2 liters of saline. That means 1 liter is bottle is half liter. Like that, 4 bottles. Not within half an hour. It should take time to go over 4 hours. That means every hour, 1 pint of fluid. That is normal saline. We are not giving hypernormal. And for 4 hours, IV, that is one aspect. Or oral sodium loading possibility. You can give sodium chloride tablets for 2-3 days, then do it. Or fluorocorticoid suppression is the other. If you do any one of these tests, then that is positive. That means still the ARR is quite high. That means that the fellow is confirmed. Okay. If the test is negative, then it is excluded. It excludes the diagnosis. If it is positive, then I have to do which is the cause. We have to evaluate the imaging. Unenhanced CT adrenals. That means you don't require any contrast. This is called fine cut CT. You have to ask for fine cut CT. The fine cut CT will reveal 3 pictures. 1, normal adrenal morphology. 2, bilateral micronodular hyperplasia. 3, unilateral adrenal edema. 3 reports can come. Okay. Unilateral adrenal mass is he less than 40 years, then go for surgery. Is he more than 40 years? If surgery is practical and desirable, you do it. Otherwise, if more than 40 years, surgery is possible, then you have to do adrenal venous sample. This is called AVS. Just like we did the petrosal sinus sampling, we have to do the adrenal venous. It's a very tricky process because adrenal veins are not easily accessible. You require an intervention radiologist. That to right adrenal vein is buried under the liver. Because the liver, this adrenal is on top of kidney. On top of that is the liver. Liver is sitting on that and right adrenal vein is not easily seen. So what you have to do is you have to put both the adrenal veins, you have to put the catheter and draw this. And whether to know whether it is in the adrenal vein or not, what we have to do, we have to measure simultaneously cortisol also. If you measure cortisol also, yeah, it must be from that. Otherwise, any vein may contain some aldosterone. The cortisol vein only will contain the axial adrenal vein only will contain the cortisol. So that is to locate the position. It's a tricky procedure, not commonly possible by physician. It should be done by intervention. Right? Okay, we did an adrenal venous sample. Positive. Positive means what? One adrenal gland is showing more, the other adrenal gland is showing less. That means this is the one culprit. Take it. Unilateral adrenal. Okay, negative. That means both adrenal veins are showing the same amount of sampling. Then it is drug resistant or MR antagonists have to be used. Drug treatment, we have to give mineralocorticoid antagonists have to be used. Okay. Bilateral micronodular hyperplasia is there. Then also drug treatment only because you can't knock off both the adrenals. So you have to use drug treatment. Suppose it is a normal adrenal morphology. Then family history of early onset of hypertension, father or mother is early hypertensive, screen for glucocorticoid, remediable aldosteronism. If that is positive, then dexamethasone 0.125 to 0.5 milligrams. Okay. We have not understood what is glucocorticoid remediable aldosteronism as yet. We will come to that. Okay. Now, the above, we have started with clinical screening, then did a biochemical screening. Biochemical screening is negative. That means there is no excess of renin or aldosterone. Rare, but renin and aldosterone both are suppressed. They both are low. That means there is some enzyme defect somewhere. Then we have to do 24-hour urinary steroid profile for glucocorticoid and mineralocorticoid. So apparent mineralocorticoid excess, that is there, HSD enzyme, or congenital adrenal hyperplasia, or adrenal tumor related disorder, or Liddell's. These are the rare. Okay. Now, from the where did we start? We started with the clinical screening first. We know what are the clinical parameters. Then we did the ARR. The precautions about ARR also you remember. Once you do the ARR, high aldosterone, low renin, primary part. You have to do adrenal imaging, decide urinatal adrenalectomy, or medical treatment. Fellow is young, straight away urinatal adrenalectomy. Fellow is more than 40, you do sampling and demonstrate that adrenal is responsible and not. If it is we can't demonstrate one particular side adenoma, but it's a diffuse bilateral hyperplasia, then we can't remove both the adrenals because we need glucocorticoids. And so we give them this aldosterone suppressive drugs, which is called mineralocorticoid receptor antagonist. What is the best mineralocorticoid antagonist? Spironolactone. Of course, you can give eplerenone also, you can. The other. And among the diuretics, amiloride is a sodium excreting diuretic. It opens the sodium channel. So you can preferentially use amiloride so that the situation is ameliorated. That means the sodium excess is taken. So it's called amiloride. It is ameliorating the sodium excess. They named it as amiloride. That's the naming. Amiloride. Okay. Now I have got a fellow who has got high renin but low adrenal aldosterone. Means adrenal gland is not the culprit. RAS system is elevated higher. What are the conditions which increase the RAS? Secondary hypertension, heart failure, liver failure, kidney failure, renal artery. We evaluate and treat. There is another group of fellow who the aldosterone is low, renin also is low. That means the problem is some enzyme defect or something. Then you do urinary mineralocorticoid and glucocorticoid evaluation and find out those fellows. So you see there, there is a kidney there, and above that kidney you see a huge adrenal. That adrenal gland will not be that size at all. A huge adrenal mass is there. So when you dissect it, the specimen looks yellow because it is lipid rich. Very lipid rich content is there. So that is called cranary yellow. It's called cranary yellow color. Okay. Now, when to consider testing primary aldosterone? Already 10 times we already told. Hypertension, hypokalemia, resistant hypertension, incidentaloma with hypertension, onset of hypertension in the young, less than 40, you can say. Severe hypertension, more than 160, systolic, whenever considered, whenever you are considered. Second. Now, accepted screening test, measurement of plasma renin and aldosterone, calculation of the aldosterone ratio, serum potassium needs to be normalized before testing. I already told. So, morning blood sample in the seated ambulant patient, plasma aldosterone concentration, that is called the PAC. A stands for the aldosterone, R stands for the renin. Renin, there are two types of measurements. One is called the renin concentration, the other is called the renin activity. Some labs measure renin activity, some labs measure renin. Either one of PAC is raised, that is plasma aldosterone concentration is increased, plasma renin concentration is lower, and the ratio is higher, means we are in for a primary aldosterone. Okay. So see the drugs, the beta blockers, they decrease the renin, increase the aldosterone, net effect ARR. Alpha blockers, neutral, they don't have. Alpha 2 sympathomimetics, they don't have any problem. ACE inhibitors increase the renin, decrease the aldosterone, and net is they decrease the AR. AT1 blockers, same. Calcium antagonists, no problem. Diuretics, net effect on ARR is not there. Because they increase both, the ratio is not effective. That's why you look at the ratio. So what drugs are suitable? Calcium channel blockers, and then the alpha blockers and diuretics are suitable. Beta blockers, ACE inhibitors, AT1 blockers are not suitable for this. What is the confirmatory? Saline infusion test, 2 liters of physiological saline over 4 hours, oral sodium loading, or fludrocortisone. So how is this test done? 2 liters of 0.9% sodium chloride solution is infused IV with an infusion pump over 4 hours with the patient in the recumbent position. Blood pressure and heart rate are monitored during the infusion. Completion of the infusion, blood is drawn for the measurement of plasma aldosterone concentration. Normal subject, plasma aldosterone concentration decreased to less than 5. Why? Because we are given sodium. When you have already given sodium, there is no business for the internal mineralocorticoid to come out. So it will get suppressed. For a fellow with adrenal tumor or adrenal adenoma or micronodular hyperplasia, this is not suppressed by your saline. It is still continuing to be more. Okay. Now, oral sodium loading test. Hypertension and hypokalemia are controlled. High sodium diet supplement sodium chloride tablets if needed for 3 days. Intake is around 5,000 milligrams of sodium every day like that. And on the 3rd day of high sodium diet, a 24-hour urine specimen is collected for the measurement of aldosterone, sodium, and creatinine. Urine aldosterone excretion more than 12 micrograms is suggestive of fludrocortisone suppression. We give fludrocortisone 0.1 milligram for 4 days every 6 hours. Combination of sodium chloride tablets, both together will suppress the renin-adrenal axis, and we are supposed to get the in a setting of low renin, plasma low renin. Failure to suppress is again indicative of primary aldosterone. Because low renin is already because of the primary aldosterone. We have given fludrocortisone. We have also given the sodium chloride. These have not suppressed the aldosterone. That's why the renin is still continuing on the lower side. Then how do I localize? Confirmed primary aldosteronism. Adrenal CT scan is done. Normal or micronodular or bilateral metanosis. A normal, micronodularity, bilateral. Low probability of this Con syndrome, idiopathic mineralocorticoid excess, pharmacological. High probability of APA, and then you do the adrenal venous sampling. Normal, there is no lateralization. Both the samples are showing same amount of aldosterone. Then again pharmacology. Only one side is showing, we know which side that you operate. Unilateral, laparoscopic, adrenal. Less than 40. More than 40. If they are less than 40 years, straight away you can think of adrenal. That's what we have already. This is a little enlargement of the same tablet. So when you do a CT, there are 3 possibilities. Unilateral adrenal mass, bilateral micronodular, normal adrenal morphology. Normal adrenal morphology, look at the family history of hypertension, screen for glucocorticoid remediable aldosteronism, and treat with, if it is positive, treat with dexamethasone 0.125 to 5 mg. Unilateral adrenal mass, age is less than 40, do adrenalectomy. More than 40, if the patient is willing to surgery and practical for surgery, do AVS, adrenal venous sampling. Sampling is positive on one side, it is more, other side is less, unilateral adrenal. If it is on both sides, it is same, no local lateralization, then drug treatment with mineralocorticoid antibody. Bilateral adrenal hyperplasia, micronodular hyperplasia, only direct drug treatment. Adrenal venous sampling, avoid about. Cortisol corrected adrenal aldosterone lateralization ratios greater than 0.4. Unilateral source of aldosterone, like in the adrenal adenoma, 95% sensitivity, 100% zone of 4 to PFR. Anyway, that is a special process. Now, how do I manage? How do I manage? Mineralocorticoid receptor antagonists are there. Spironolactone, lacilactone, you are getting a tablet combination with Lasix and spironolactone. And there is a separate tablet also is available at 25 milligrams. So, all that time you have to give. Are valuable in treating the hypokalemia and hypertension in all forms of mineralocorticoid. So 20% of males develop gynecomastia. This is one drug-induced gynecomastia. Okay? Because of spironolactone. Amiloride of 10 to 40 milligrams, which blocks the epithelial sodium channel. EC, E is epithelial, Na is sodium, C is channel. Epithelial sodium channel blocker. That means there is no entry of the sodium into the cell. Sodium is left in the uterus. That is X. So that is the alternative. People who go on to gynecomastia who are not able to tolerate spironolactone, you can give them amiloride. Okay. In patients with APA, that is the aldosterone, primary aldosteronism, with the adrenal adenoma, primary aldosteronism. Medical therapy is usually given for a few weeks to normalize the electrolyte balance before the adrenal. Laparoscopic surgery cures the biochemical abnormality, but hypertension continues to remain because the target organs are irreversibly damaged organs. So younger than 40 years, confirmed mineralocorticoid excess, unilateral lesion, go straight away for surgery. Laparoscopic adrenalectomy is preferred. Who are not surgical candidates or with evidence of bilateral hyperplasia based on their CT or the adrenal venous sampling, they should be treated medically. Spironolactone starting dose is 12.5 milligrams, max up to 50 milligrams BID, up to a maximum of 400 milligrams you can give. Side effects, menstrual irregularity, decreased libido, gynecomastia, particularly. Eplerenone, more selective mineralocorticoid antagonist, 25 milligrams BID, it can be titrated up to 200 milligrams, a little more expensive. This is a selective mineralocorticoid receptor antagonist. Now, another useful drug for the sodium channel blocker is the amiloride. So how much is the dose? 5 to 10 milligrams BID you have. This is the management. Okay. So I think that is the end of the story. Now, I'll ask you a few questions and answer how far you have understood. Okay, still some time is left. 10 minutes is there.